and a, and a PhD student at McMaster University in the School of Nursing. By background, I nursed in pediatric intensive care at McMaster Children's Hospital, and I'm still working with children in my research, specifically children with medical complexity. So those are the folks that I'm going to be talking about today. So now what I do with my team is essentially try and meet the healthcare needs of Canadians using virtual care and digital health methods. And so that's been a really interesting journey, especially now going through the COVID-19 pandemic. As you can imagine, virtual care demand has really skyrocketed. So it's been a really interesting journey trying to adapt systems quickly to meet the needs of those folks. So I'll be presenting our paper, a generative co-design framework for healthcare innovation, development and application of an end user engagement framework. I'd like to acknowledge my team. You can see the co-authors listed at the bottom of your screen there. I am really blessed to work with a really highly motivated, passionate, intelligent group of people. And certainly this project would not have been possible without them. So let's just see here. There we go. What are we going to talk about today? So I'm going to take you through the steps that we used in my group to co-design a virtual health innovation called DigiComp Kids. And we'll talk about, what the product is, but I want to specifically focus on kind of how we got there. So my ask of you as the audience is, if you could take a moment to think about, if this is applicable to you, a healthcare challenge that you're working on with your team. So something that, maybe a problem that you're trying to solve, maybe an innovation you have in the works, or maybe something that, hasn't come to fruition yet, but you're it's percolating in the back of your head. And I want you to start by thinking about the why you do what you do. So the why means, the what we do and the how we do it is constantly changing. In digital health, this is a pretty fast moving field. So new methods, new products are being introduced all the time, but the why you do what you do, that's kind of your guiding light or your beacon. Starting there, I think, can be a really great place for starting to understand the problem that you're trying to solve. And so for us, the why we do what we do is that families and clinicians face unique challenges when caring for children with medical complexity in Canada. So that's our why. And we'll get a little more granular with that in just a moment. The what we do, so this project was about innovating what's called DigiComp Kids. So that's a virtual sort of hospital to home system for supporting children with medical complexity, their families, their home and hospital healthcare clinicians. And the how we do what we do, well, that's the framework that we're going to be talking about today. So this co-design framework is sort of our, what we used in order to innovate within our local healthcare system. And we used it to partner with who we call end users in the digital health space. And that just means people living and working in the context of your innovation project. This really includes patients, families. For us, it also included frontline clinicians, healthcare decision makers, so on and so forth. And I'll highlight specifically the roles of our family partners who were on our team throughout this presentation. So getting a little more granular, why we do what we do is really because of kids like Drew. So this wonderful little boy here, you see his name is Drew, and Drew is a child that I worked with when I was nursing in the pediatric intensive care unit. As you can probably see here, Drew is a child with medical complexity, and he's actually quite complex as far as that goes. So you might be able to see Drew uses tracheostomy to breathe. It's at times connected to a ventilator with supplemental oxygen. He is fed through a G tube. which is a tube that goes from the external environment directly into his stomach to help him eat. He uses things like braces and orthotics. He sometimes wears hearing aids. He has a suction machine. He has a long-term intravenous line. So, Drew has a lot going on. And so because of this, and for a multitude of other reasons, Drew was actually with us in the pediatric ICU quite a lot. And I got to know he and his family quite well. And after one particularly acute episode where Drew did need life-saving care in the ICU, Drew stayed with us for an additional 3 months beyond when he was medically ready to go home. And the reasons for this were simply because it takes so much to care for a child like Drew in a home environment. So there were problems getting the resources in place, including the supplies and the people being trained to come into the home and give Drew the care that he needed. We really don't have a seamless, comprehensive system to care for medically complex kids outside the walls of the hospital at the moment. And so if you can just imagine this, being Drew's family and Drew himself living in an ICU bed for 3 additional months as a child, that really does take a toll. And so to illustrate, our family partners on this project are both mothers of medically complex kids. And a quote from one of our family partners, I think, illustrates this really well. So she says, "Our reality is daunting and scary. We can feel isolated, and even the closest members of our support network may not know how to help." And so I think this really speaks to the isolation that these families can feel, the anxiety, justifiably so, that these families can feel. And so this really, for us, became our why. So keeping Drew in mind, we didn't know what we wanted to do, but we knew that we wanted to make things a little bit better for Drew and children like him. So Drew's story is unfortunately not that uncommon. So to give you an idea of children with medical complexity, or CMC, we don't have reliable data for the entire country of Canada, but in any given province or territory, CMC typically make up less than 1% of all kids. So in Ontario, my home province, this sits at about 0.67%. So despite them being quite a small population, they consume 1/3 of provincial child healthcare spending. So let that sink in. Less than 1% of kids are using 1/3 of provincial health resources. And most of these resources are going toward acute care. So things like emergency department visits, hospital admissions and readmissions, but this number also includes home care, community care, school care, specialist care. So most of these kids are going to be admitted to the hospital at least once or twice a year. And of kids who are admitted and then discharged home, almost a quarter of them come back to the hospital within 30 days. And this really, I think, illustrates the lack of that comprehensive care outside of the hospital walls for these children. So 14% of these we know are preventable readmissions. So things like, blocked feeding tubes, or sometimes not even having the supplies or resources to be able to get care at home, results in a hospital admission. For children and families, this impacts them in a huge way, resulting in decreased physical and mental health and quality of life for both family members as well as these kids. This is important to know because this is the context in which we're trying to innovate. So having a good idea of Drew and his story, but also a little bit broader about the population and who we were working with in Ontario was sort of where we started. Now, we didn't know exactly, again, what we wanted to do, but we did know that it was vital to innovate with the help of our patients and families, the people who live this reality every day. Even myself, being a healthcare provider by background and working in this environment, I knew that I didn't know a lot. So I kind of knew what went on in the hospital, but outside of the hospital walls, things like, getting supplies and resources, scheduling healthcare providers to provide home care, what happens when these kids go to school. There was a lot I didn't know. And so in that sense, I'll say our patients and families who have worked with us on this project have been absolutely key. So why include patients and families? I don't think I have to tell you this. There are a multitude of reasons, only a few of which are listed on the screen. Some of them are philosophical, moral, ethical reasons. Some lean more toward being pragmatic and logistical reasons. But I think one universal truth that we can all agree on is that patients and families are key members of health research and health innovation. Now, when you get into digital health, there are a few intricacies about involving patients and families there, or any health innovation for that matter. So there is a gap that we talk about in the digital health world between the postulated benefits of health innovation. So what we think they can do, the problems that we think that they can help us solve, and the actual outcomes of these innovations when they're deployed in practice. And I will say they often fall short of their predicted benefits. So these, really great ideas don't always pan out and result in the desired outcomes like improved patient health or decreased hospital admissions. And so the thinking around this is that oftentimes health innovation teams, health researchers like myself, with lots of energy and passion and a drive to make things better, innovate without bringing in our end users, again, those people who are living day to day the situation that you're trying to improve. And so while you may think that you're solving the problem, perhaps it doesn't really end up meeting the needs of the people who are actually going to be using it, hopefully, in practice. So in our project, we got to thinking about what we were going to do and knew that at some point we were going to bring in this digital health virtual care. And so the next step for us was really to think about how do we bring in our end users, our patients and families and clinicians on the ground floor to help us get started. So I'd like you to meet our team. As I said, I'm really lucky to work with these folks here. Up top, you can see our two family partners, Shannon and Elizabeth, with their beautiful families, and they've been involved with this project from the very beginning. We'll get into their role a little bit as well. And we're also very lucky to be working with folks from Ontario Health, formerly OTN, the Ontario Telemedicine Network, and they're helping us kind of with a big picture view of this project and deploying it in practice, as well as our tech innovation company called Cloud DX. So family partner involvement, I'd like to just touch on this for a moment. I think, it may be a little bit unique in this study and could be interesting. So our family partners, Shannon and Elizabeth, who you met on the previous screen, they kind of held dual roles. So one within the larger DigiComp Kids study and one specific to the co-design piece. So within the larger DigiComp Kids study, we brought in Shannon and Elizabeth to sit on our steering committee. So they were integral members of the research team. We recruited them by having lots of discussions around what their role would be, their expectations of us, our expectations of them. But we did not go through an informed consent process with them for their role in the larger DigiComp Kids study. And I think this is important because, this was a really purposeful move because we were looking to recruit team members. So just as if you would recruit another researcher, for example, you wouldn't necessarily undertake informed consent for them to participate on your project. And so we felt the same here. So lots of discussion, but not an informed consent. And what have they done in the larger study? It's honestly, what haven't they done at this point? So both have participated in from the very beginning in things like grant writing for us. They've assisted us in setting those project priorities, so really steering the project and where we're going with it. They've advised us on methodological decisions. They've co-authored papers, including both of them are co-authors on this one. They've co-presented work with us. And they're paid by a quarterly stipend, which I think is also important. So they are not paid out per their hours put in. As you can imagine, being moms of medically complex kids, among many other roles that they hold, they're very busy. So, they kind of let us know what their capacity is, and it shifts, and that's okay. We have lots of discussions about what they can and can't take on at this moment in time within the project. In co-design specifically, so both Shannon and Elizabeth vocalized to us that they really wanted to have their voices included in the results from co-design. And to do that, they wanted to participate more along the lines of research participants for this specific section. And so that's what we did. So just like everyone else who participated in our co-design process, they underwent informed consent. We talked to them about the postulated benefits, the risks to this research. And within the co-design portion, they were able to share experiences and challenges. So being moms of medically complex kids living in this system, they actually facilitated a portion of our co-design day. They actively participated in our co-design exercises. So ours was called a persona scenario exercise. I'll tell you a bit about that. They were involved in member checking, so making sure that we kind of got it right. We were representing well the voices of co-design participants, and they were paid as research participants. So just like everyone else, they were given a small stipend to say thank you very much for your participation in research. So I just wanted to highlight those dual roles, if that's perhaps of interest to this group. Okay, so we've talked about our why, and now we're going to get into the what a little bit. So we had a few aims of our project called Digicomp Kids, and those aims were we wanted to create a hospital-to-home care system for medically complex kids and families. So we were going to use virtual healthcare. We knew we wanted to fill that gap from the hospital to the home, create better lines of communication, perhaps be able to monitor children a little bit from home and do some proactive care instead of sort of the reactive care model that we have a little bit right now. So that's what we were aiming to do. We knew we wanted to co-design the system with end users. So lots of people on our team, myself included, have been involved in co-design efforts, further back than this project. And it really made sense for us as a way to bring in people on the ground floor and let us know what the priorities were. And we also knew we wanted to integrate these creative methods into the co-design process. And if you've read the paper, there is an emphasis on these creative methods. So I just want to touch for a moment on that. So creativity is actually a really essential component of innovation. So generating novel ideas or applying old ideas to new problems, creativity is really key for that. And we knew as a team that, the old ways of doing things weren't really working. So sometimes if you ask people who are entrenched in and living and working within a certain system, how do we make things better? It's very hard to get your headspace outside of the system that you know. So we really wanted to shake things up, and we're looking for some out of the box ideas. So this is why we brought in these creative methods. To push this a little further, we used generative techniques. It's in the title of the paper. I'll talk a bit about generative techniques, but just to prime you, what we're doing here is generative techniques aim to map what we call latent needs. So really dig deep into the roots of what the challenges are and what would be the needs that would be met with different solutions. So that's what we were really aiming to do in the co-design process. So our research question, when we knew we were designing this hospital-to-home virtual system, was what are the optimal processes, features, and workflows for a virtual care intervention to provide integrated home-based care for children with medical complexities? So that's the question that we wanted to answer using our co-design process. Okay, so now we're going to jump into the how, which is really how did we go about co-designing? This is the generative co-design framework. And again, we see these generative techniques. So our aims are we're channeling creativity, we're drawing on people's lived experiences, and we're trying to construct what are called alternative future states. So getting out of the box that we're sort of working and living in right now, what might be an alternative sort of reality in which we're solving some of the challenges that we know we're facing right now. So those are the aims of generative techniques. So our co-design framework came about because there's been a lot of work done, a lot of different frameworks made that are excellent and very strong to involve end users, patients, families in this engagement in health research. Tricia Greenhall, who probably some of you know, is a brilliant health services researcher. So she and her team in 2019, I believe, conducted a systematic review. They cataloged over 65 patient engagement frameworks to support, evaluate, or report on patient engagement in health research. And though a lot of the parts of each of those frameworks were really relevant to us, there wasn't a framework that spoke specifically first to health innovation, which is a little bit different than some health research, and then bringing in those creative methods, which is something we were really kind of set on doing. So this is how this came about. So we see here 3 stages of co-design. So we have pre-design, co-design, and post-design. So in pre-design, we start with contextual inquiry. And what this means is you're going to really try to understand from all angles, what is the challenge that you're working on? So thinking back again to at the beginning of the presentation, I asked you to think about your why. So what is that challenge that you're really hoping to make a difference on? So you can do this in lots of ways. We did a lot of observational field work. So this really just means going into the context in which you're trying to innovate and really trying to look at things with fresh eyes. So we did days in the complex care clinic. We were on the inpatient unit of complex care, really trying to see things that maybe we hadn't picked up on before. And we also did a lot of informational interviewing. So trying to engage with people across the healthcare spectrum who could help us understand this problem. So patients, families, clinicians, also healthcare decision makers, including those in the hospital, those from home care, system navigators. So we really wanted to try and understand this problem from lots of different angles. In step 2, you're going to prepare for your co-design. These 2 steps, I will say, if you're thinking of undertaking a process like this, it's helpful to put in time and effort here. It will pay off in dividends and give you a really rich co-design experience. So you're going to invite participants to undertake your co-design with you. The aim here should be to create a diverse team. So people with different experiences, different voices, different challenges. So you really want to try and get a good representation of different folks to help you with your challenge. Preparing materials, if you're conducting this virtually like we did, testing technology. What are you going to use for co-design? What platform? Is it Zoom? Is it, another technology platform? Making sure everyone's comfortable with how to log in, how to participate is, it seems a little menial, but it's really important to do. Both to establish a base level of comfort and just to make your co-design day flow smoothly. So in co-design, you can do this virtually, as I mentioned. You can do it in person if COVID ever lets up. You can do it in one session, multiple sessions, whatever fits your needs, really. The first step within the co-design stage specifically is to frame the issue. So you're going to ask co-design participants to share some lived experiences in a large group format. Sometimes it's helpful to prime people a little bit ahead of time and say, hey, if you're comfortable, I'd love you to be able to talk about this in our co-design day. The goal here is to determine what must change and develop a shared vision for that at the very outset of your co-design experience. I would say it's very important here that you're a skilled facilitator, because what you're asking people to do is pick apart the system in some cases that they live or work in, which can be challenging to do, especially if you've maybe never met some of the people before. So really establishing that we're not here to place blame, we're here to understand challenges and work towards solutions. It's important for people to be honest, what gets said doesn't leave this group, and so on and so forth. So that's an important piece in that step. And step 4 is probably the most fun, I would say, of this whole process. That's our generative design. So what you're asking people to do is, in some way, engage in some creative exercises, and you're going to get them to create something. We call this an artifact. An artifact can be anything. It can be a story. If you're innovating a product, maybe you're getting them to do like a creative prototyping exercise. You can give people Play-Doh and popsicle sticks. It doesn't matter. Get them to do something creative, to create something at the end of the day that gets them thinking a little bit outside of maybe their comfort zone. And what you're looking to do with this is determine a future state of care. So, we establish the state of care and frame the issue in step 3. Now we're looking to identify possible future states. So what could be, basically. For us in DigiComp Kids, we did a persona scenario exercise. And so this is really where you're pairing people off into small groups. You're getting them to work together to create a persona. So it's someone like them, I will say. So maybe if you have 2 parents of medically complex children, they're creating a persona that is another parent of a medically complex child. They're developing it. So how old are they? What complexities does their child have? Where do they live in relation to the hospital? So they're really going in depth here. And then picking a few challenges that this persona faces in their day-to-day life. The next part is the scenario part. So you're asking people, okay, if these challenges were solved, what would care look like? So what would be different? Perhaps a challenge is that they live quite far from the hospital, and it's a challenge to get to just child visits. So maybe part of the future state is that you have some virtual methods. So you can connect virtually. Maybe you can take some vital signs at home and transmit those to your hospital-based team. So those are the types of things that may come up in your future state. The last part of co-design is you are getting groups to present their personas and scenarios to each other. You're exploring ideas. So what was similar between groups? What was different? What challenges did people choose to work on? It would be really helpful here if you're undergoing a process like this to audio tape this part with participant consent, because it will help you when you're going through your data analysis to really make sure that you're representing correctly the participant voices from your co-design. So in post-design, first you're going to analyze your data. So you're going to have lots that you gathered, audio tapes, maybe some worksheets. We had a few of those as well. So getting that all together, getting your audio transcribed, organizing and coding it however makes sense for the type of data you collected. We used thematic analysis. And then we went back to our co-design participants with the themes that we had pulled and said, can you make sure that this is representative of how you experience the day, what needs to change, and so on and so forth. And then you're going to go into requirements translation. This is the last step. From here, what you're really aiming to do is take things from the sort of hypothetical and get them into action items. So really practical action items. So you're going to see from your themes, what came up that people said were necessary components of a future state of care, and then what can we do about those? So what are feasible priorities for our new system? To give an example, if folks said, we really need one shared medication record that's up to date, that people can log into from different devices, and that really tells a very clear story of what needs to happen when. Maybe you work with a company on a cloud-based solution that's, log in, find the document that you're looking for. Families can use it, healthcare providers can use it, and so on. So that's your requirements translation stage. Those are all the steps of co-design that we used. I'll just leave you with a couple of lessons learned, and then we can open things up to questions. So my takeaways from this were investing time in understanding the problem is really key. Kind of knowing what you don't know is good, and then finding people to help you understand those angles that are beyond what you know already. Including as many diverse voices as possible. So people with different experiences, different challenges, that was helpful for us. Making your co-design goal to facilitate a conversation among a group of experts. So the reason you're bringing people together in co-design is because they know best their reality and what needs to change in a future state. So as much as possible, sitting back and just facilitating the conversation is a helpful thing to do. And then, of course, end user perspectives are critical. So pay attention to what people are telling you and carry that forward into your product. The last thing I'll leave you with is a quote, again, from another one of our family partners, her experience of the co-design day. So she says, the co-design process was enlightening. As parents, we're usually only used to reporting on what clinicians ask for. By designing the system with clinicians and other health professionals in industry, we were able to make this project the most meaningful it could be for all users, including parents and clinicians. So that was her experience there. And I'll just leave up for a moment. My contact information is right at the bottom of this screen here. My email is bird, BIRDM, like Michael 3, at mcmaster.ca. Please reach out if you have any questions that don't get to come up at the end of this session that we're going to do now, or if you have a problem you're working on that you want to talk about. And I'd also like to acknowledge our funding partners for this project, CIHR, the Canada Graduate Scholarships Program, as well as the Norman Saunders Grant Competition from the Hospital for Sick Children. So I think I'll end there.